So we shall now go on to our next speaker, Dr. SHRINIVAS M JOSHI, who's going to be talking on the other aspect, choriocapillaritis. On to you, Srinivas.
Yeah, good evening, everyone. At the outset, I would like to thank Team ARC and Chitra Madam for arranging this wonderful discussion and the webinar. So, as Dr. Chitrandan has covered the most of the things, I just want to bring it to the notice here that we all know that the dye goes into these choroidal vessels and then they try to leak out. So we need to know that the ICG, as he described, has around 700 and odd Daltons of the molecular weight. But when it comes to ICG with protein complex, then it becomes quite heavier, around 50,000 to around 80,000 Daltons. So that is why I think ICG is most preferred in these kinds of either the choriocapillaritis or in cases of the stromal choroiditis. The another advantage is, you have these fenestrations in the choriocapillaries, and probably that is the reason for the filling of the choriocapillaries and causing the choroidal fluorescence. But however, if we see the retinal vessels, they are tight junctions, they are impermeable. So the leakage of the sodium fluorescein shows that the vessel is inflamed. So here I just want to bring up another slide which differentiates between the two, where I divided this topic as the stromal as well as the choriocapillaritis. In the choriocapillaritis basically happens in the choriocapillaris level, and the non-perfusion is basically due to the loss of the choriocapillaries. And here, but in case of stromal choroiditis, because there is no filling of the dye into the stroma, I think this causes the blockage. And because the dye doesn't flow into this space, and because of these inflammatory lesion, and that is when we get more commonly the hypocynosant or the hypofluorescent areas. So coming to the inflammatory choriocapillaritis, you can see here these inflammatory choriocapillaritis are basically the geographical areas where you can see they are pretty much irregular type 1 geographical area of hypocynosants. And Dr. Chitranjan has nicely described choriocapillaritis. We describe into the primary, where he described of the stromal. So I'll be describing about the primary is basically where we have this mutes, AMPI, or we have the multifocal choroiditis or the serpiginous choroiditis. And the secondary could be due to any other infections like the TB or due to the syphilitic causes. In the stromal choroiditis, he has nicely explained it is mainly because of the HDDs, and these HDDs are round, numerous, and they are evenly distributed. But however, in cases of stromal choroiditis, we see after the treatment, the good sign is these fuzzy indistinct choroidal vessels, which we are not able to see in this slide. So after the initiation of the IV steroid therapy, you can delineate these choroidal vessels again very distinctly. And you can see these HDDs, what were there, have been partially resolved. So stromal choroiditis, he has explained it. It could be a primary or the secondary due to infectious causes. Octa also is a very important tool. It's not only used for the superficial or the deep vascular plexus, but definitely we also use it in the choriocapillaris as well as in the choroidal area to know the choriocapillaris void areas, that is flow void areas. So this is how you can see this is the case where you have the hypocynosance here in this case. And definitely you can see the corresponding OCTA in this. If you look into it, there's definitely a choriocapillaris flow void area, which definitely indicates that this could be a case of AMPI. So in this, if you can see here, this is another case, 18-year-old female, diminution of vision in the right eye, few paracentral scotomas and a decreased field of view. The patient, although had 6 parts vision, but patient was symptomatic, and you can see some yellowish lesions here. Although it's not very seen very nicely over the clinical pictures, but when we did the FAF, I think FAF is another interesting modality, and you can see there is a hyperautofluorescence in these areas when this corresponding to the angiography, which is not showing any much in case of fluorescein angiography. And definitely, if you can correspond it to the OCT, you can see some areas where there is loss of the outer retinal layers, and even in this area, you can see there is a loss of the outer retinal layers. So the patient was, since it was symptomatic, the patient was started on steroids. Then after 2 weeks, we can see the FAF, how nicely it's trying to resolve. And definitely, this is almost a result. The patient had 6/6 vision and was not very, is basically asymptomatic. So basically, it's the mutes where we have the young myopic women. They usually have flu-like symptoms. It's usually unilateral. The patient present with subjective scotomas, photopsia, diminution of vision. In the earlier faint discolored, 100 to 200 microns has been described along the temporal arcades or the posterior pole or the mid periphery. They resolve well. But however, when we see
1
these
minute
kind of
remaining,
picture,
sir.
when we see this kind of picture, there's basically a granularity. So this granularity is what makes that this patient had a mutes before and is now improving. So this is again the OCT and ICG and FFA. You can see here the hyposinusant area here, which is increasing in the late phases, and also corresponding FAF. You can see this areas of hyperfluorescence is there, which shows that progressing of the disease. So in mutes, we see ICG is hypo early, hypo late. In OCT, there is loss of photoreceptor outer segment. But however, in AF, we can see hyperfluorescence, this exposure of RP lipofuscin following the loss of the outer photoreceptor segment. So this is the another case where you can see yellowish white areas here. You can see here some hypopigmented areas. And definitely when we do the ICG, you can definitely see these kind of hyposinusant areas. There is on OCT is also an NSD there. And in the late frames of the ICG, these lesions are very well delineated. They are clear. And again, FAF can definitely show the hyperfluorescence areas here, which tells us that there is a disease activity. And after initiation of treatment, now you can see definitely there was good improvement and the NSD was resolved. So these are the case of AMPI, where we see most commonly in the young myopic woman. One eye may be affected first, and the subjective scotomas, photopsia, and diminution of vision is probably based on the location. So in case of AMPI, also follows the same rule, that is early hypo, late hypo. OCT shows the loss of photoreceptor, and FAF shows that there is hyper FAF, but hypo in cases where there is atrophic lesion due to the previous episodes. The associated CNS involvement is very important in case of AMPI, especially when the patient presents with headache and have mimicked the migraine with kind of aura. So another thing, just last two things I want to cover is the PIC or the multifocal choroiditis. They are usually, the characteristics are lesions tends to leave the scar, that is a numerous scar randomly distributed, recurrent behavior of the disease, and the propensity to develop secondary neovascular membrane are more common in cases of these diseases. And again, you can see these hyposinusant small areas which are getting more delineated in the later frames of the ICG. But if you see the FFA here, you can see the pooling. It's basically the reactionary kind of hyperpermeability of these vessels where we see the pooling in cases of FFA, as contrast to ICG where we can see the more of the hyposinusance in those areas. So this is again a FAF picture which shows the progression, and after the treatment we see there is a complete resolution. And if you look into the 10 degree of visual field perimetry, you can see these areas corresponding to these, they show kind of scotomas. But again, after the initiation of treatment, you see the less of these hyposinusant areas, and definitely, although very few areas are there, there are very less scotomas as recorded in the visual fields. So the last one is the serpiginous choroiditis. It's the most severe end of the spectrum, progressive, recurrent, and usually the patient are elderly with scotomas and the metamorphopsia. Here, the importance I wanted to make here, the difference between the FA and ICG is, although FFA shows hyperfluorescence, but the correct delineation of what is the exact lesion of this scar is definitely shown better with ICGA as compared to the fundus fluorescein picture here. And definitely you can see there is a kind of hypersinusance surrounding this area, which shows that there is a disease activity. So the delineation of these kind of scars or the disease progressive is much better in case of ICGA as compared to the fundus picture alone or in cases of FFA. So this was the last case. I just wanted to show the patient already presented with this picture, and this was the picture when they presented. The patient had 612 vision, and this is the FAF picture where it shows a lot of hypoautofluorescent areas, already scarred up areas. And here, along with the hypoautofluorescence, we see some hyperautofluorescent areas, which shows that the disease is progressing. So this is basically a kind of relentless kind of serpiginous choroidopathies which keep on moving. So this require a very rapid kind of IV steroid treatment. And if it is associated with Montus or like serpiginous like choroidopathy, I think it is always better to add AKT also along with the pulse steroid and the oral steroid. So here, in spite of adding these, you can see the relentless disease progression in these kind of SLC like cases. So lastly, I would like to conclude with this slide that in case of mutes, there is a regular involvement of the end capillary vessels, which are reversible. But in case of AMPI, there is involvement of the precapillary arterioles, which are again reversible. However, in cases if you see MFC and serpiginous, it is the irregular involvement of the precapillary arterioles and as well as the larger arterioles. And because of the onset, the subset of the disease, it's usually irreversible. And the response to the treatment is basically how early we start and how hard we hit on these kind of cases. So just I would like to end up telling that the choriocapillaris inflammation, we saw it as the mutes, AMPI, multifocal choroidal serpiginous. And in case of stromal, it has been nicely described by Dr. Chitranjan, where we have primary obligatory stromal choroiditis, where we explain about the VKH, sympathetic, and the birdshot. And in the location of the systemic disease, definitely the sarcoidosis and the tuberculosis and the syphilis is what falls into the classification. With the interest of time, I would like to thank Department of Vitreoretina and my dear fellow, Dr. Rohan Dediya, for helping me in this presentation. Thank you very much for allowing me to present these cases.
Yes, a very wonderful talk, Srinivas. Nothing less was expected from you. So we look forward to Dr. George for the discussion.
Thanks, Srinivas, for covering the inner choroidal inflammations, choriocapillaritis. So in this, as you have beautifully shown, basically the inflammation involves the inner choroid and RPE level. So there are some diseases which are very widespread and severe, like as you said, serpiginous choroiditis and multifocal choroiditis. But there are subtle diseases which one could miss actually. So I would just to stress upon these diseases, which almost one thing is the level of the lesion. Some of them are outer retina, some of them are RP and choriocapillary lesions. For example, what you showed, the mutes, almost normal clinical picture. So I think we have to be aware that patient has subtle symptoms, but then it is very important to have a fundus autofluorescence, fluorescein angiography and ICG angiography, which shows so much of findings in these mute patients. For autofluorescence, as you showed, hyper autofluorescence, but normal looking fundus almost. And hypo on ICG, hypocyanosis on ICG, and the wreath-like around the arcade, wreath-like hyper granular hyperfluorescence. These are all classics of mutes. So mutes, basically, we know that it's an outer choroid, like outer nuclear layer and the ISOS junction, ellipsoid zone. That is where the inflammation happens. And as you have rightly mentioned, in the other entities like APM, PP, you have the RP and choriocapillary inflammation, and that produces this hypo on ICG. And as you rightly mentioned, the precapillary arterioles are narrowed and there is a less leakage because of the inflammation, less leakage from the capillary level. That is why we are getting this hypo on ICG and things. So rightly said. So two more entities just to bring in, because they also look almost normal fundus on top of what you have added. One is RP epitheliitis, and next is acute idiopathic maculopathy, unilateral acute idiopathic maculopathy. They also have inflammation at the level of RP and the outer retina, showing ellipsoid zone hyperreflectivity, loss of ellipsoid zone in both these conditions. Wherein RP epitheliitis, classic finding is this granular pigmented cluster of granular lesions at the fovea, and in acute idiopathic maculopathy, you have this yellowish, whitish, gray outer retinal lesion with the thickening of the RP. So it's very important to differentiate these from what Chitranjan had mentioned, the outer choroidal inflammation. So these entities are very important, and fluorescein angiography, ICG, and fundus autofluorescence, as you have nicely demonstrated, has to be done in these patients to differentiate these entities.
Thank you very much, Dr. George, for summarizing it so well.